Thank you. Thank you for the invitation. Today I'm going to talk about the evaluation of vaccine effectiveness. For COVID. So far there are more than 700 million COVID cases and more than 7 million deaths attributed to COVID worldwide. So vaccination has been a major tool in combating this pandemic. So here is the outlines of the major decision by FDA for the deployment of vaccines. So first of all, vaccine first become available, or they were initially authorized in December. Yeah, it's difficult to see. In December 2020 for the mRNA vaccine, and then later for the J&J vaccines. And then find out that the vaccine were actually not very, the effectiveness actually decreased over time. And so we had the boosters that started in September of 2021 for different vaccine and for different age group. Eventually, booster were given for everyone. Well, I then find out again the booster effectiveness also were not very lasting, and they were not very. The vaccine were not effective against the newer variant. So in 2022, we have the what I call the second generation of vaccine. So in the previous this vaccination, even though it's a booster or the original vaccination, it still is the same vaccine. Okay, but then in October of 2022, we had a so-called bivalent vaccine. So they're targeting both the Omicron variant that's circulating at that time, but also the other half is the original variant. Okay, so this is called the bivalent booster. And then a year later, we have another generation. So this is the third generation of the mRNA vaccine. Now it's going back to monovariant. So they're only targeting the circulating variant in the spring of that year. So it was the XBB.1.5. So let's first look at the clinical trial. But by the way, the clinical trial will only used for the original vaccines. Later on, for all these other the booster or the bivalent vaccine and this update, it was the third and second and third generation vaccine. There was no clinical trial. Okay, so this is the original clinical trial. So here is the outline for the Moderna trial, but the Pfizer trial was pretty much identical. Okay, so subjects were difficult to see here. The subject entered the study for about 3 months, over 3 months period, and then they were randomized to the vaccine or placebos. Okay, and then data were presented to the FDA, and it was approved, or EUA was issued in December. And then after that, subjects were allowed to cross over. Well, it's not really crossover. And people who already vaccinated, they just stay. They don't, they didn't do. I mean, not receiving the placebo, right? But the subject originally received placebo. Now were given the vaccine, so they had the option to get a vaccine. Eventually, virtually all the placebo participants received the vaccine. So it's the crossover here. So when I first got involved in this, I was trying to figure out how we analyze this data to look at the crossover, because if we want to look at the vaccine effectiveness, the variant vaccine effectiveness over time, we need a little bit more than the 3 months. So by the way, when you heard about this 95% vaccine efficacy, that's actually really for the first 3 months, or actually only for the peak. So the subject entered the study over 3 months period. And so on average, they only follow for about 3 months. And then in the analysis, the first month of data was thrown away because the vaccine, it took a while for vaccine to be effective, right? So if you include the first month of data, in fact, your effectiveness is not going to be 95%. And at the 1 or 2 months, that's the peak, that's 95%. And then afterwards, it actually decreased. So the actual vaccine effectiveness, the efficacy is not 95%. It's only 95% for the peak. But then, we're interested in using the crossover data to at least to figure out the vaccine effectiveness over maybe 4 or 5 months rather than just up to 3 months. So that's what the first thing we try to do. And so in this case, we treat everybody as potentially vaccinated. So it's really not in analysis, not really in our model, it's not really like a placebo group or vaccine group. I mean, that only applied to original randomized clinical trial, but when you have crossover, then basically everybody eventually will be vaccinated, just when they were vaccinated. That's the time varying exposure. And we also want to have a time varying effect because the vaccine effect change over time. Then the other thing is that, in the randomized clinical trial, we use the time of randomization as the time zero in survival analysis. But in this case, time zero, in fact, because for people who are everybody is potentially vaccinated, there's not really, what we usually the randomization data, right? There's no randomization data for people who actually receive the vaccine data on. So, so we actually use the beginning of study as the time zero, which actually turned out to be a very important consideration when we discuss the vaccine effectiveness in the real world setting. But anyway, so here again, the time zero is the beginning of the study, and then everybody will have this time to vaccination, and time to infection. Okay, and then of course the vaccination again is time varying. And this infection, we want to estimate the effectiveness on vaccination, vaccination on infection as a time varying effect. So this is the model that we use. Okay, again, everybody have a S and a T, and again it's on calendar time. Again, this is a little bit different from say in cancer clinical trial that we're not going to use. But this for infectious disease, this actually is important because the background infection rate actually changes over time. So anyway. So S is the calendar time at the vaccination, and T is the calendar time at the occurrence of infection. And X is a set of baseline risk factor, which is not important for clinical trial, but for observational study, that's going to be it's important to adjust for this baseline risk factor. So this is our model. Okay, it's the cost proportional hazards model. Without S, okay, if you ignore the variable S, then lambda T given X equal to lambda not T e to the beta transpose X. That's a standard cost proportional hazards model with time independent covariate. Okay, but S is that's the interesting part for in our case. Okay, so first S is a time varying exposure, right? So this indicator will take a value of 1 if the subject has been vaccinated. So this is indicated by time t, calendar time t, if the subject has been vaccinated. Okay, so that's the time varying exposure. And the time varying effect is that the effect of vaccination depends on how long ago you're vaccinated. So if T minus S is equal to 3 months, that means that the person has been vaccinated for 3 months. And we want to know what's the vaccine efficacy at the 3 months. So this measure from the time of the vaccination. Okay, so the gap, the time elapsed since vaccination, that's the time we are interested in estimating this function, eta. Eta is a log hazard ratio, but it's time varying. Okay, later on, we will actually allow this eta function also depends on the calendar time of vaccination. But so far, this eta only depends on the time elapsed since vaccination. Okay, anyway, so that's what we want to estimate. Okay. Well, cost model is a semi-parametric model. So lambda naught is non-parametric. If eta is also purely non-parametric, in fact, it's not identifiable. So what we do is that we actually use a B-spline function for eta. Okay, but But anyway, so eta is the hazard ratio, and a log hazard ratio. So E to the eta is the hazard ratio, and the vaccine efficacy is 1 minus the hazard ratio. So when we say 95% vaccine efficacy, that means hazard ratio is 0.05, which of course is a very, very extreme value. So anyway, so that's our model. But if you look at the vaccine COVID vaccine literature, no one used this model. Everybody is using constant proportional hazard model with a constant hazard ratio or p-squares. Okay. So originally, like the Pfizer and Moderna trial I just showed you, they just assume a constant hazard ratio. But in order for that to hold, again, they throw away the first month of data, and then they maybe they estimate the average over months 2 and 3, and they give you the 95% efficacy. That's why it is. But if you want to study the waning effect of vaccine, then you need to allow eta to somehow depend on time. But again, we allow eta to be a continuous function of time, which makes sense. But the other people, they just divided the time period into several windows, and they just estimate this average effect. It basically assume a constant hazard ratio within each interval, and then estimate this effect over every 2 months. So that's was actually reported in by Pfizer and the Moderna study in the New England Journal of Medicine. So this is actually the second paper these 2 trials were published. The first paper was just publishing the original 95% efficacy. But in the second paper for both studies, again, they have crossover. Now they have about 5 to 6 months. And so they can estimate a little bit of this waning effect to see, if vaccine actually efficacy actually decrease over time. So for the Pfizer trial, they just did exactly what I just said. They basically broke this into 2 months, So first 2 months, next 2 months, and then the last 2 months, and then the estimate is average hazard ratio over 2 months, and 1 minus the hazard ratio give you the vaccine efficacy. So the efficacy they have is the first 2 months is 96%, which is consistent with the original report of 95%. And then the next 2 months, months 2 to 4 is 90%. And then 4 to 6 is 84%. Okay, so that's what you have here in the. I just plot those 3 estimates and the 95% confidence interval at the midpoint of that time interval that they were these estimates was correspond to. Okay, so this is so I argue that this is not very informative because if I want to decide whether or not I want to give booster at the 6 months, I want to know what's the vaccine efficacy at the 6 months. And if you tell me is the average vaccine efficacy in months 5 and 6, that's not really 4 to 6 is not really. It's basically estimating average at month 5. So if you tell me it's 84% efficacy, I don't know what to do at the 6 months. But if your efficacy is 70%, that's informative. If 70%, maybe that's too low. So I want to have booster. Okay. So anyway, but what I showed this solid curve is not the actual data. I just put the least square to the 3 point on the log scale, and then I plot it. So I guess it's 70%. But in fact, we actually never known because the data was never analyzed. They never published. So in fact, we actually don't know what's in the original trial, what's the vaccine efficacy estimate at the 6 months. And for Moderna, we actually have the data. So we actually estimate the vaccine efficacy as a function of time. And this is what we got. But unfortunately, it's not very informative because the confidence interval is so wide. But also Moderna's vaccine was more effective. So maybe they still had 90%. But actually, that's important. If you say, okay, it's still 90%, there's no need for booster. But anyway, so this information is very limited. So we for clinical trial, because of the crossover, of the 6 months or 5 months, there's no one on the placebo. So it's very difficult to estimate the effectiveness, even of the 5 months. So we turn to observational studies. Okay, so this is the first paper that was published in the New England Journal of Medicine. So we look at the vaccine effectiveness in North Carolina over 9 months period. Even though it's one state, North Carolina had more than 10 million people. So it's actually a very large data set. Okay. And so, so there is a surveillance surveillance system, which was, very complete in the beginning. Okay. So we know, whoever tests positive for COVID, and then they were followed to see if they were hospitalized or they die. So actually the data were very complete. In the very beginning, they were very complete. So the local health department actually conducted this investigation into the outcomes of the infection. So we not only we have the infection, but we also have hospitalization and deaths. And then vaccination data, or this vaccination management system, which was actually perfect, at least for the first 2 or 3 years. If you vaccinated, it's in the database. Anyway, so this allowed us to study the vaccine effectiveness over a 9 months period. And so the model we use is the same as the model I showed you earlier. That's actually the reason I want to show you the other model. But in the real world, it's a bit complicated. In the one clinical trial, you only have people who are vaccinated, receive one vaccine versus placebo. So you only have one exposure. But in real world setting, people could receive Moderna, they can receive Pfizer, they can receive J&J. But then also, some people only receive 1 dose, some people receive 2 doses. So there are actually 5 types of exposure. You can have 1 dose or 2 doses of Pfizer, 1 dose or 2 doses of Moderna, or you have J&J. So there are actually 5 of this vaccination. 5 of this, so I use V to denote the vaccine type. So 5 exposure. But the model is still very similar to what we before, except I have 5 exposure and then 5 log hazard ratio, eta function. Eta is still T minus S. It's a function of the time since vaccination. Okay, but also I allow this model to also this eta, this log hazard ratio, to depend not only on how long ago you were vaccinated, but also the calendar time you're vaccinated. Because when you are vaccinated, in terms of calendar date, will determine the sequence of the variant you will experience in the future. And so this is important in terms of understanding how vaccine effectiveness depends on the circulating variant. Okay, so this is actually a 2-dimensional function. One is time since vaccination, the other one is the calendar date of vaccination. Okay. For some of our analysis, we actually have both dimensions, but some of them will just be T minus S. Okay, but again, we estimate all 5 of them. And yeah, as I mentioned, North Carolina have 10 million people, so this is a very large data set. Even at that time, this is that in 2021, we still have almost 1 million COVID cases and 20,000 hospitalization and almost more than 7,000 deaths, even in one state. So anyway, so that's one of the most important results is that, first of all, we estimate this curve, right? So we actually can estimate where the peak is. So that's one of the contributions. So we know actually peak occur at 2 months. Okay, so you can see the peak for Moderna and the Pfizer, they are about 95%, which are consistent with the clinical trial results. And then they decrease over time. Again, to estimate this as continuous function over time is kind of the main features of our work. And so you can see here, after 6-7 months, the Pfizer is about effectiveness about 70%. For Moderna, it's a little bit higher. Okay. By the way, Moderna is a higher dose, right? So it's expected to be a little bit stronger effect. And so this is actually one of the studies that was used by CDC to argue for booster, because your vaccine effectiveness was only 70% after 6 or 7 months. Okay. We also look at different age group. And this is the one that actually I mentioned earlier, have this 2-dimensional for the log hazard ratio. It depends not only for time since vaccination, but also the calendar time of vaccination. So this red curve is for people who are vaccinated in the very beginning, December of 2020 to January 2021. What's their vaccine effectiveness compared to the unvaccinated change over time. And then green will be the next vaccination cohort and so on. And this gray area is the percentage of Delta variant that was circulating. So you can see when the Delta variant increased, the prevalence increased, all these curve will have a drop here. So that means that there's a decrease of vaccine effectiveness over time naturally, but also there's the emergence of Delta variant also reduce the effectiveness of vaccine. Okay, so this is something that's not available in the clinical trial. The clinical trial only look at infection, but in the actual observational database, we actually have hospitalization and death. So this is the new information that was not in the clinical trial. Not only that we actually estimate the vaccine effectiveness against infection over a longer period, but we were able to look at the hospitalization. And of course, not everybody knows, but at that time, this was still, new at that time that we actually estimate the effective against hospitalization and death. It was very high, was over 90%, even after 7 or 8 months. And against death is also very, very, very high. And so this was actually, some people actually use this data to argue that against booster, because they argue that, well, if your effectiveness against hospitalization and death, that's all you care, it's 90%, then there's no need for boosters. Okay? In fact, there's some FDA people who actually published an article in Washington Post, and they cited this data, but those people will eventually resign from FDA. So eventually, the booster, anyway, that's the paper I mentioned here. This paper. But anyway, so this the same data were used for for CDC to say, okay, you should use you should have booster because the effectiveness against infection was below 70%, but also used by some people to argue against booster because effectiveness against hospitalization or death was still over 90%. Okay, so that's our first paper. Then by the time our paper was published, we had Omicron variant, and then so people were asking, what's the effectiveness against Omicron variant, and also because the booster was people receive booster. Now we want to know how effectiveness was a booster. And then the other thing is that when we were writing that first paper, or in the beginning of the pandemic, people believe that once you get infected, you're not going to be reinfected. But pretty soon we realized people could get reinfected, and then so there was a question of how much the immunity you receive from natural infection. So in our second paper that was published in JAMA, this is a very complicated paper. Look at all these questions. Look at the effectiveness of the primary vaccination over a longer period against infection, hospitalization, and death, but also look at the effectiveness of the boosters, and then also look at infection of the effective of the natural infection, the previous infections. Okay, and I'm not going to get into detail, but it's a lot of the results in this paper. I don't think JAMA have ever published paper with such complicated figures. So let me show you some of the figures, but the model is very similar to before, but now the natural infection is also become a time-varying exposure. So we're estimating the effect of vaccination, primary vaccination, boosters, and previous infection, all in the same model. And also in some model, we also look at the interaction to see if your vaccine effectiveness actually depends on if you already have infection or not. But anyway, so this is against this is against it's a primary vaccination, and the last figure here is about I think this is the effect of the previous infections, and this is what I mean. This figure is so complicated. Look at the different vaccination cohort, previous infections, And or this a booster, this or maybe this was a little bit surprising. Booster actually were not very effective. It basically after 3 or 4 months, the effective was 0. But we are talking about effectiveness of booster compared to no booster. We are, if you compare to unvaccinated, of course that still be high, and against hospitalization and death was high. Okay, but then the other thing I think it was important is that we find that of course not everybody knows that basically this previous infection work about the same as a booster or vaccination. It only lasts about 6 months. After 6 months, your chance of getting reinfected is high. But if you have a previous infection, it actually protect you against hospitalization and death. So if you get reinfected, your chance of being hospitalized and dying actually are low. Okay. So that's that's that paper. They will also look at the effectiveness against children because the data, again, there's no clinical trial on children. And so all this data about effectiveness, vaccine effectiveness in children will become from observational studies. So yeah, so it's very similar, against infection, and this is this effective a previous infection, very similar to what I showed you before. It's not basically after 8 months, the previous infection doesn't give you any protections. Don't. Okay, so that's the first part of my talk. That's about the first generation of the vaccines. Do you have any questions? So now I'm going to talk about the second part. My talk is about this bivalent. First part talk about this bivalent booster. So this is the second generation of the vaccine. So this vaccine was deployed in September 1st of 2022. Okay, so when we have this called a bivalent booster, when this vaccine come out, it replaced all the previous. So the first generation of vaccine were taken off the market, so they're not used anymore. And so, but I was interested in a lot of people were trying to figure out what's the effectiveness of this new this bivalent booster. Well, I mean, I know it's going to be effective, but I think the more interesting question is it really better than the previous generation? So that's what we try to figure out. Is the bivalent vaccine more effective than the first generation of vaccines? So how do we do this? Because they were not given to people at the same time. So how do we do the comparison? So again, on September 1st, 2022, we all switched to this new bivalent vaccine. So what we did is that we picked 2 months, right? So from September to November, September 1st to November 3rd, roughly 2 months period. That's when we first have the data. For this 2 months period, we estimated the effectiveness of this new the bivalent vaccine. Okay, and then we also estimate the effectiveness of the previous, the first generation of vaccine in the preceding 2 months, so from July 1st to September 1st. And what I show you in this different color is the proportion of the circulating variant in the population. So you can see that during these 2 months, before and after, the circulating variant was primarily this BA.5, or maybe some other BA.4. So that's what I argue, because because the effectiveness of vaccine will depend on the circulating variant, and because the circulating variants were very similar between these 2 periods. So I argue that we can compare the vaccine effectiveness for the new vaccines in this and the older vaccines. Okay, because if the circulating variants are different, then you say you compare the effectiveness, it's not going to be a fair comparison. So we argue that was a fair comparison. Well, by the time we actually revised the paper, we extended the data a little bit, about 3 months. So 3 months after, 3 months before, that's how we estimate this. So this is how we actually show that the vaccine, the bivalent vaccine was more effective than the previous monovalent vaccine. Okay, so for example, if you look at hospitalization, okay, monovariant booster, this is the previous, the first generation of vaccine, the effectiveness is only 25%. But for the bivalent booster, it was 58.7. If you take the difference is 33.5. And because these subjects actually overlap, so we actually use bootstrap to come up with the confidence interval. So the lower limit of the confidence interval excludes 0. So statistically speaking, we show that the bivalent booster was actually more effective than the monovalent booster. To my knowledge, this is the only study that actually proved that the bivalent booster was more effective than the monovalent booster. So this is our first paper on this bivalent booster. Then the second question is how long the bivalent booster remain effective. So we look at this, the durability again, just like what we did before with the other booster. So here are the results. So the effectiveness was not very high. It's only like 30% even at the peak against infection. Against hospitalization, it's a little bit higher, maybe 50, 60%. But they all decrease over time. And so then FDA decided to have another variant another vaccine to target the XBB 0.1.5. So basically, I don't know what happened in the future, but in the last 2 or 3 years, so FDA looked at the variant that's circulating in the spring, and then divided. I mean, not them, but the company divided vaccine that's employed in the fall. And so in 2023, in the spring of 2023, the circulating variant was XBB 0.1.5, and so the vaccine that was deployed last year, in the fall of 2023, was the vaccine called the updated vaccine. But everything is updated, so it's very confusing when you just say updated. But it's actually targeting the XBB 0.1.5. But anyways, but this is the one before that. This is the bivalent vaccine. But every time, of course, you have a vaccine that's targeting the variant in the spring, circulating the variants, and then you had a vaccine that's deployed in the fall, you have a new variant, right? But anyway, so this is still the result about the bivalent vaccine. So these are a couple of papers published. I mentioned 2 papers. One is to show that bivalent vaccine was more effective than the monovalent, and the other one was this durability of the bivalent vaccine over time. So this was published in New England Journal of Medicine. So I should mention that when we were doing this work, we are a little bit behind Israel, because Israel actually deployed the vaccine before the US. So a lot of the publications, we see a lot of actually from that you heard of is from Israel. But the bivalent vaccine will actually deploy in the US, in about the same time as Israel. And because we actually did our work very quickly, so we actually were able to beat the Israeli this time. We actually published these papers in New England Journal of Medicine, but they were not. So this paper actually received a lot of attention because we are basically the only one who published this paper on the bivalent vaccines. Okay, so then I wanted lastly, I want to talk about this the so-called update vaccine. This is the 3rd generation. Yeah.
People are getting infected and getting their own sort of self-induced immunity over time. How does that play into your model?
What you account for that? I mean, in my previous paper, when I mentioned about this, in all analysis, you adjust for previous infections. Okay, and so in that JAMA paper I mentioned, we actually look at this very extensively. But we already figured out the effect of previous infections, so we're not interested in that. We are interested in booster. But when you look at the booster, you ordered the new generation of vaccine, you need to account for the previous infections. And then if you so it is adjusted for.
It's like a covariate, the model.
Yeah.
Look at effect modification.
So So again, like in our JAMA paper, we look at the estimate of vaccine effectiveness among people who have previous infection versus people who don't have previous infection like that. So yeah, so we also look at that, but we also look at here too. We actually look at the vaccine effective against people who are previous infected, people who are not previous infected. And the results are shown in the supplementary table. But unfortunately, the data have become more sparse. So the confidence interval overlap. You can't really tell if they are any different or not. So what I've shown you so far is all based on North Carolina data. But the data actually become the quality of data become lower because those COVID cases they're not first of all not all of them were not reported anymore because of home testing, but then also the vaccination data actually it become it's not very not complete anymore. In the beginning it was 100%, but in the last couple of years now I don't know what's right now, but even a year or two ago it was not very good. But in Nebraska, they still have relatively good data. So from our last paper, when we look at this effectiveness of vaccine, the third generation of vaccine called updated vaccine, but it's really targeting XBB 0.1.5 vaccine. I used to use the Nebraska data. Okay, Nebraska data unfortunately have a small sample size, 1.8 million people. But we look at these results. So this is actually very interesting or important the figure. So again, we show that the vaccine effectiveness was lower against infection than against hospitalization and death. But we also look at again for all analysis, we look at this, what I mean in the two-dimensional, time varying vaccine effectiveness. So vaccine effectiveness actually is stratified by different vaccination cohorts. So in this case, for people who vaccinated before October 25th versus after. So you can see here, and this here, this area on this area underneath is the proportion of the circulating variant. So first of all, the vaccine effectiveness, first they peak about 4 weeks, and then they will decrease over time. And then also, the effectiveness was lower for the second cohort was lower. So this is against this green one is actually the JN.1 that was circulating at that time. So this actually was so when FDA decided in the fall, in the spring of 2023 to have another generation of vaccine targeting JN.1 that's deployed in the fall of 2024. This is actually the data they use. Maybe they already come up with this idea, but I sent the paper to them like a week before the advisory committee meeting. But this actually was the figure they used. And so the vaccine effectiveness decreased over time, but also it was less effective against JN.1. And so that was the rationale for having the new vaccine that targeting JN.1 that's deployed in the fall of last fall. So if you are taking the vaccine right now, is the one that's targeting the JN.1 that was deployed. So that's the fourth generation of the vaccine, but we don't have the data for that. Now the qualities are not there anymore. So I don't know, maybe we'll never really have the study on those JN.1. I mean, the newest vaccine that was deployed in last fall. Also, not many people are taking the vaccine, so it's difficult to estimate that. But yeah, so that's the last paper again was used by the FDA. I think I'm going to. I think that's my last slide on my I have. So I'll be happy to answer any questions.
I have a question. Is there a good analysis of how many deaths were caused by people not taking the vaccine?
Good, very good question. we have another paper that's I'm not showing here. We look at the cumulative incidence. And so what I'm showing here, all this vaccine effectiveness is the relative risk.
Right.
And so from the relative risk, in fact, you don't know the number of lives saved. But if you look at we really need to look at the absolute risk or look at the actual cumulative incidence. And so we have another paper, but it's not I'm not showing here, that we look at the number of the number of the cumulative incidence of hospitalization or cumulative incidence of deaths for people who follow different vaccination schedules. So if you only have no vaccinated, you only have primary vaccination, you have primary plus booster and all that. I think that's a very it's a very important question, right? If people you argue that, okay, some people concerned that what the data I don't have is the adverse event, right? So how many deaths were caused by vaccine, whatever. People argue about that, right? So whatever that is, that number is much smaller than the number of deaths that saved by vaccination. I can tell you that. But again, that's in our paper, we will show the number of deaths that for people who follow different vaccination schedule, the number of deaths, of course, is. But you also can look at this, even by looking at what I said earlier, how many, we have 7 million deaths in the world, right? 7 million deaths. If the vaccine effectiveness is 95%, 90% against deaths, you can see how many deaths we already saved there. So, so if you know, I've been thinking about it the other day. Unfortunately, I don't know how complete the mortality data are. But if you know the number of deaths, in the state, for example, during this COVID period, you can also easily do that because I know the relative risk. So you can also calculate the number of deaths that's saved by vaccination.
What's your best estimate?
I don't have an estimate. I don't have an estimate, but if you think about it, if it's 90%, that's a lot, right? I don't know. I seriously, I was thinking about writing a paper on that, but if I can get some good data, I don't know, these days it'll be difficult. It will be easy to get a number, but I think that's very important when we talk about the adverse effect of vaccination. We should think about how many lives have saved from vaccination, and but maybe there's somewhat confidential. I'm actually reviewing a paper for the New England Journal of Medicine but it's from France. I haven't read the paper yet, but they're looking at this question. Pardon? They're looking at.
I think it's a good question.
It's a good question, and I wish I could do the same thing for the U.S. But I think I don't know if I'll be able to get the data. But there is a study from France that looking at the deaths over the last 3 years. And I think that's a very, very important question too. But I can tell you it's a very big number. It's much bigger than whatever the other side effect that you can think about of vaccination. But,
Don't you compare different regions of a country which have vaccination rates and you get Rod's question a little bit?
Yeah. We know the rate of vaccination in different countries, different states. But I think we also, I just don't know. Can we get all the mortality data? If we can get the mortality data, then you have the relative risk. You can apply this, this relative risk to all these. But I can't really estimate the actual number on our data because the deaths and hospitalization they probably were underreported in our database. But if we can get the mortality data from from whatever the state and then we apply this relative risk to that, then you can get some numbers. And then, then of course you can also apply to a different vaccination rate in different state to actually calculate the actual number of lives saved. But it's very, it's very obvious that even you look at the, these vaccine effectiveness against hospitalization and death, they were pretty impressive. Even though, against infection, the effectiveness is very low right now. But anyway, that's a very good question. I think like to
And then have you also looked at the interaction like between demographics, like senior people, young people?
Yeah. We are. I mean, not. I mean, actually even in our first paper, we have actually that was very interesting, important question. And we look at this for different, the second figure I show you this for different age group, different age group. Okay, but vaccine effectiveness was a little bit different among different groups. So actually, I was invited to CDC to present these results because we actually look at this, like effectiveness against children. At that time, there are not a lot of data on this. So you can see here, vaccine effectiveness was lower for the older people than for the younger people. This is the fourth generation of vaccine, the primary vaccination. And it's not really, I don't think I have the other one. If you look at our paper, we also look at other demographic, all the other demographic variables like, race, ethnicity, gender, and also different regions. But age is the most important factor. I don't think vaccine effectiveness is changing that much between male and female, but or between different ethnic group. But it's definitely different among different age groups.
Yeah, I have a more general question. I guess, can you talk about the cause from the causal point of view? Because you have later on you have observational studies, and what is the how there's some kind of discussion about Cox model, the interpretation of Cox modeling from causal point of view. So I want to get your input on that.
Well, but what you ask is much more general than this. But I don't know which part you're talking. Are you talking about using the Cox model, or are you talking about the fact this is observational studies? I mean, that's different, two different.
Right. You're using you're using Cox model as well, and this is also observational study.
Yeah. First of all, I'm not really trying to. First I'm not really trying to, making a causal statement. What we estimate is just the effectiveness, and that's what you observe in your data. Now, in terms of observational study, it is observational study, but first of all, we adjust for what the very important confounding is the time varying confounding. Time varying because a lot of things change over time. But because we use this calendar time as the time scale, so we're comparing people who are vaccinated versus people who are unvaccinated on the same calendar date. So that's why we remove the confounding due to time trend, because the infection rate may be different among the circulating variants are different over time. So you really cannot compare people who are vaccinated versus people who are unvaccinated at a different time. But because of the time scale we use, so we account for the time we account for the time varying confounders. So that's good. Now, in terms of the other confounders, I mean, in the beginning, I think the vaccination was, most people, were vaccinated, 60, 70%. I don't think there's a lot of selection at that time, but we adjusted for all the demographic variables, socioeconomic variables, and different regions. But one thing we don't have is if the U.S. surveillance data, we don't have the comorbidities. So that was the main limitation compared to the data, say from UK, they have comorbidities. So we did not account for comorbidities. And also I'll argue that when you see an effectiveness of 90%, and so you believe that result, even, I mean, it's effective, even account for confounding, of course, it's not going to explain away, such a big effect. And also in some of our later paper, we use internal control. So I compare the vaccine effectiveness, say after 2 weeks versus vaccine effectiveness in the first 2 weeks. If you assume vaccine has no effect within the first 2 weeks, which is, of course, is conservative, right? It has some effect, but assume there's no effect. Then the vaccine effectiveness at some point, say 6 months, divided by the vaccine effectiveness over the first 2 weeks, that will give you actually an estimate out of vaccine effectiveness. That's internally. Suppose the vaccine, suppose the infection rate does not change over time, then I can look at the vaccine effectiveness in 6 months. I mean, the disease incident at 6 months versus disease incident on day 1. That will give me an estimate out of vaccine effectiveness. But again, we use this internal control. Actually, the people who are likely to be infected actually are more likely to be vaccinated. No. So if you don't do this any adjustment, sometimes people got negative estimates of vaccine effectiveness. But it's slightly negative, maybe 10%. But if you do this, you do internal control, you can actually can have some adjustment. I mean, you can have a better estimates of this vaccine effectiveness. Again, that's another way to account for confoundings. Any other questions?
Yeah, I have 2 questions. The first one is about how you collect the incident. Because, for example, some of the outcomes are self-reporting out. Usually, share data including those.
So in the first few paper that based on North Carolina data, again, in the beginning, the COVID, the infection was only detected when you go to went to a testing center, right? So everything was captured. If you did test positive, it's captured in the database. And then this local health department, they follow these people to see if they are hospitalized or deaths. That's how the data were collected in terms of the infection, hospitalization, and deaths. That's pretty good for the first paper, or maybe for the first paper. I don't think there's any issue. When we have that second paper, it become an issue in the latter part of the study, because now you have home testing. When home testing, the home testing results are not included in the state database. So we missed those the home testing results.
I wonder, because vaccinated may go less to, not very frequently to the hospital to report their incident compared to unvaccinated, because they may feel confident about their health. Probably, this lead to overestimate of the vaccine impact.
Well, it depends, depends, because you can argue both ways. People who are vaccinated, maybe they are more health conscious. They may actually want to go to hospital.
Yeah.
So you can argue both ways. So testing is okay. Then the other thing I want to emphasize in that in our second paper, I don't remember which one, but in our later paper, we didn't even look at infection. We only look at hospitalization and death, because if people death is obviously it's not a problem, because if people die from COVID, that's in the death certificate. So in our last paper, we actually look at the death certificate to figure out. So I think the data on mortality was very solid.
Mm-hmm.
But the hospitalization, if people hospitalized because of COVID, that's also a good outcome to look at. But infection, we couldn't trust any data on infection, because we don't know who actually will go get tested. So that's very incomplete and maybe biased. But the hospitalization and the deaths, I think the data were good.
Yeah, my second question is about also related to Mengang's question. Have you ever looked at the direct versus indirect protection from vaccination? Because indirect, you want to make policy, you want to reach a certain percentage of vaccine rate, right, among community? And have you ever looked at like, for example, after we have achieved certain level of vaccine rate, how does that increase or decrease the vaccine effectiveness?
Yeah, no, we don't, because we only look at population level. We don't look at this interference. So we only look at I mean, that one will only change the background rate. But we only look at relative risk. So we don't think we have that, yeah. Yeah, that's yeah.
Thank you.
But if you really look at the actual incidence, I think you can do that. But we don't really look at accident. We don't even really trust the incidence data because of underreporting. So we really focus on the relative risk. Any other questions?
Time.
Oh, perfect.
Let's bring questions on.